It's time to start.
Yes. Very warm welcome from Germany. We expect a huge snowstorm tonight in our area, but we're sitting in a cozy room in our clinic, and I'm very happy to, together with my colleague and friend Thomas, to celebrate our bone ring technique today in this webinar. We did this today for international people, and here you see our doctors from our clinic. On the left side, Andriana, she is on the way to be an implantologist, and Thomas and me, we are already implantologists, and Thomas is a maxillofacial surgeon, and we are working together in a clinic here in Kassel, and we are very happy to found each other, and because we have a very good relationship, and also I think a very successful clinic. And now I hand over to you, Thomas. I think you want to tell something about yourself.
Yes, and our clinic. Just a little bit. Hello to everybody. Hello, dear colleagues. I'm happy that you're with us today, that you joined this webinar. And just a short introduction about our clinic in Kassel. We are in the center of Germany, we can say, and have a dental office for dental surgeries, oral maxillofacial surgery, augmentation implants, of course. And this is the view to our entrance. You can see we have only 4 seats for the waiting room. Because we don't want to have any patients that they have to wait for the treatment. This is one of our treatment rooms. We have 3 of them. This is my colleague Bernd. He's trying to explain somebody about the bone ring technique. Yeah, our colleague Adriana Neuert. And this is myself from the back. We have under the roof, we have a small room where we are sitting now for our hands-on courses. Before Corona, we gave about 4 or 5 hands-on courses a year about bone ring technique with live surgery. And we want to start again in autumn this year with the next course. Hopefully, yes. Yes, that's me. I'm oral maxillofacial surgeon. I got my education for maxillofacial surgery at the military hospital in Hamburg. I was a soldier for 5 years, and after that I worked in a dental office in Hamburg, and then I went to Bern 1.5 years ago, and now I'm working here, and I'm very happy that we are colleagues now. You know my channel, Augmentation and Implants. I started with this Instagram channel about 2.5 years ago, and here I want to show, or I want to repost great augmentation procedures and implantation procedures from all over the world, and everybody is invited to tag me in his text in his news feed for the case he wants to have reposted. And it's only me who is working on this channel, and if I like your post and if I think it's a very good procedure, I'm very pleasant to repost it at my channel. Together with Bernd, we founded the Institute Pro Implant. It's an education program for dentists and surgeons for dental implantology and augmentation procedures, of course, bone ring technique we lecture a lot, and we have some education for young dentists, surgical basics. Yes, almost every course we have live surgery, and you can watch the surgeries on the big screen we have today behind us. And that's one of our basic surgery courses. This was about 2 years ago in Hamburg with great anatomical models and it makes a lot of fun to us and to give these hands-on courses. So that's a short introduction about us, and then we get right into the topic.
Yes.
And you want to begin.
So, and then now I will start with a case I did many years ago, and this is for me like an introduction to show you a standard indication for the bone ring. We have a huge defect in the frontal area and aesthetic zone from the frontal maxilla, and this is, from my point of view, the biggest challenge, because now here for the aesthetic outcome, and every single millimeter counts to get a nice aesthetic outcome. So this is a huge challenge, but again, this is for me one of the standard indications, best indications for the bone. Usually I make a crystal horizontal incision and then 2 vertical cuts into the fibulum. This vertical cut should be done between deepest point of the gingival margin and papilla. Never at the deepest point from the gingival margin and not in the papilla, directly in between. And then we make this vertical incision into the fibulum and I raise the flap to the buccal side. And after that, it's visible this patient had 2 or 3 failed augmentation procedures before, and you see there's a bone graft material part of the bone graft, only connected, disconnected, and I have to remove everything. And after removing this material, you see there's a huge defect. There's no buccal bone, no palatal bone. This is a very difficult defect design because we have to lift up vertical 4, 5, 6 millimeter from the defect. And this is a really big challenge. And now I measure the bone covering the roots of the chosen teeth. This is my orientation laser of the vertical. Don't put him higher and not deeper, exactly on this level. Now I measure the defect with a refine, and in case the bone is covering the roots from the adjacent teeth, we leave a distance of approximately 1 millimeter, not to come too close to the surface of the root from the adjacent teeth. And now make a furious incision to release the flap. This is very important if you do it right after raising the flap, because later you avoid hematoma and swelling because bleeding stops later. In this case, I go with the chin area, and with the right incision technique, I expose the bone at the chin area. Later we will talk a little bit more about this kind of details when you have a bone or the chinese bone in different areas. Now I mark the position of the bone ring. I go only half a millimeter into the bone and start up my implant bed preparation. With a round drill, I mark the center, and with all the other instruments, I penetrate the cortical bone on the bucket side, I penetrate the cancellous bone, and go in contact on the lingual side to the cortical bone. I use all instruments from my implant system to make a preparation of the implant bed at the donor side, and then we create with this procedure a ring designed graph. And after finishing my implant bed preparation, this is, for example, a conical reamer. This is the instrument from the ankylosing implant system, and this is used finally. And after finishing my implant bed preparation, I use the refine for the final refine cutting. So refine should be used intermittent, good cooling, not too high speed to avoid the overheating of the bone cell. So this refine penetrates the cortical bone, penetrates the cancellous bone, and go in contact with the lingual cortical bone. You feel that contact very briefly. And then we have an instrument called a ring knife, and this is ring knife separates the cancellous from the cortical bone on the lingual side. And then I remove the ring with brass, and then you see the effect cancellous and the cortical brass. And then I suck out blood out of the defect and store the ring in the blood. And these are some small cancellous chips filling up the defect with a collagenous sponge. and close with the donor side. In the receiving side, I mark the position of the implant. The position is the most important, that you insert the implant on the right position. Everything is orientated on the right implant. And then we create a ring bed. The ring is now inside on the level of the bone, covering the roots from the teeth. And now I use the ring as a cap. I make my implant through the ring into the local bone and insert my implant through the ring into the local bone. And some and gives compression to the ring down into the local bone, and then we have a very stable fixed ring. And now I fix the membrane with 2 titanium pins. This is a collapsidious membrane coming from a pericardial pig. And then I use bone graft material and put a thin layer of the particle in bone graft around my graft. And then I fix the membrane under the palate. And now I use a technique so-called double layer. I make an incision of the inner side of the buccal flap, and I make a mobilization of the periods out of the prolongate the flap with the periods. And then with 2 vertical muscle sutures, I pull the period under the palatine mucosa. This is my first layer. And in the second layer, I close mucosa on top. Advantage from this technique is I have 2 layers of soft tissue on top of the graft. If the first layer gets open, I have a second one down for protection of the graft, and I increase the thickness of the gingiva, and this helps me later to get a nice emergence profile. Hello? So, and now you see the X-ray follow-up. This was a defect before, and now this ring, the cortical and the cancellous part are compensating this defect. And you see the function of this fixation cap. If the ring has a little bit mobility left, I insert my fixation cap together with a cover screw into the implant, and then I get compression to the ring down into the local bone. And you see very nice the cortical part and the cancellous part of the ring, and how this changing after 3 and 6 months to trabecular structured bone, very stable situation. There's no bone resorption, and after 6 years, we see have a stable bone on top of our shoulder of the implant. This is exactly what we want to have. And this is how the soft tissue looks like half a year after bone ring healing. This is not the same case from the videos you have seen before, but this is also, I did a bone ring, autogenous bone ring case, bone ring graft, and close the gingiva, and after 6 years, 6 months, it looks like that. And now the re-entry has to be done to get a nice emergence profile. We want to create papillas, and we want to put the gingiva back where it was before to get keratinized or fixed gingiva. And this we do with the so-called meander technique. I go with my blade from the buccal side deep into the palate, turn around on top of the implant, go back to the palate, and go back to the vestibulum. And then I raise this flap to the buccal side, and you see the implant is not visible. It means the bone ring is vital bone, and bone is grown on top of the implant. And after removing this bone on top of the cover screw, you see we have a very stable situation. The implant diameter is like that, so it shows that bone is growing actively on top of the shoulder of the implant. I put the gingiva former in, and now I make a transposition from this small tongues coming from the palate between gingiva former and adjacent teeth. I make a transposition from here to here and separate this tongue on the palate spread left and right, and suture. And these are my new papillas coming from the palate. And with this procedure, I put the gingiva back to the buccal side where it was before to get a symmetric situation like a keratinized gingiva. And this you can leave for secondary healing. And now we want to show you a video from this kind of procedure. This is 6 months later after augmentation with the bone ring, and because of the mobilization of the mucosa, I have no keratinized gingiva and no papillas. And this is another technique I create again this elegance profile, make it symmetric with the other. And again, here you see this is only the tunnel of the cover screw. The bones growing actively of very stable bone situation after 6 months of healing. Now I put a gingiva in, and I make a transposition from the small tuck coming from the palate between gingiva former and these are my new papillas, and we get new nice keratinized around the back. And now the suture. And we usually recommend after suturing, if there are some granules, to cut them to take the tension away from this granules to the papilla in between. Okay, this is a so-called meander technique. And this is the X-ray follow-up. This was a defect before. The ring graft compensates his defect. In this case, the ring was stable, so I don't need a fixation cap additionally. 4 years after loading, and this is now the situation after prosthetic restoration. We have now papillas, and we have nice keratinized gingiva, symmetric to the other side. Nowadays, we do it a little bit in a different way. I want to show you on a case like that. We have a central incisor, internal resorption has to be extracted. This was a clinical situation before a surgery. Here was a internal resorption, and I remove this central incisor. And now the problem is we have no buccal bone, but we have a very nice gingiva design, very nice and healthy. If you now do your augmentation with a ring and implant, then you have to cover this defect. It means you have to make vertical incision, and you destroy this nice gingiva design around your teeth, around this defect. That's why we do it nowadays a little bit in a different way. I go with my trephine to the tubera, and with the trephine I go through the gingiva into the bone, deep into the bone, and I harvest a bone gingiva graft from the tubera. And this I put into the socket, and with this procedure I compensate a part of the bony defect, and also I have a gingiva graft to keep the soft tissue design. We start the surgery with a bone gingiva graft or the augmentation from the tubera. You see it here. And this is before extraction, and this is 3 months later. And now we are ready for augmentation. And again, I measure the defect. There's a defect left, of course. Go to the chin, harvest the bone ring, fix the implant position. And then again, this is very important. Everything is orientated on the right implant position. With a template or with a surgical guide, I fix the implant position. And then we have a trephine with a pin. And this pin comes now into the pilot drill and guides the trephine to the right position for the ring bed preparation. Then we put the ring inside vertically on the level from the bone, covering the roots from the adjacent teeth. And you see how nice this ring fits into this ring bed. And we fix the implant. And another advantage from the bone ring technique is the design by itself. You see how nice we can reconstruct the UG alveolare with a ring design graft. Bone graft material on the buccal side, fixing the graft with an implant and cutting the frenulas. And this is after suturing the donor and the recipient side. 10 days later, you see the donor side, healing is absolutely nice. 10 days later, X-ray. We used to insert our implants always a little bit subcrestal. This is 10 months later. This is now before putting the prosthetic restoration inside. You see, we have a very nice soft tissue design after ring graft augmentation. Here we make laminates and crowns and the transfer key for the abutment. And this is the situation before treatment, and this is after prosthetic restoration. You see, we have a very nice soft tissue design. We have papillas, we have keratinized gingiva, and 2 years after loading, we have a very stable bone on the shoulder of our implants. This is 2 years later. So this was a basic, this was an introduction for the bone ring technique. And now I hand over to Thomas, and he will talk a little bit about basics.
Yes, thank you.
Thank you.
I've heard that we have some problems with the audio. I hope it's better now. Let's start with the basics. I think almost everybody of you knows the basics about augmentation procedures, but for me it's very important that everybody in this webinar knows the basics, and so we start a little excursion about 5 or 8 minutes in this topic. What to do if we have a loss of bone and when we want to place an implant. How to regenerate the bone. Almost we have 4 different kinds of bone augmentations, the most common ones. At first, we have a bone split. You can use the bone split if you have horizontal bone defect, and if the defect is on the outside of the bone, and then you split the bone in the middle and you push the bone to the outside. In the middle you can place an implant, and you have very stable conditions in the middle where you do this split. And stable conditions are very important for bone healing. We have transplantation, sometimes not that easy and not that predictable. I will talk about it a little bit later. Special kind of augmentation is the sinus lift. Here again, we have very conditions for inside new bone, and it will become put almost anything. And the last one, guided bone regeneration. We all know that we have a scaffold for the bone to grow in, and we have to use a membrane to avoid soft tissue cells to be faster than the bone cells. And the bone ring technique is a kind of guided bone regeneration. So augmentation or successful augmentation depends on an immobile space or tent, and that's the most important thing. Soft tissue cells shouldn't migrate into the bone or in the augmented area faster than bone cells, so we have to use barrier, or we have to avoid the migration somehow. Of course, we need blood supply and nutrition so that bone precursor cells can grow in. And if all these points are if you follow all these points, then cellular regeneration can follow. The take-home message here is we need space, and the space for the new bone has to be stable. We need stability, and of course, we need neovascularization. Especially with the bone block, we have problems because on the one hand, it's a very stable condition for new bone, but sometimes it's very hard for the new cells to grow in. Sometimes it's like a calcified massive block, and you get problems that it will adapt to the local bone. This here was a bone block transplantation from the retromolar area, and 4 months later the reopening, and we can see that this is just a sequester. It's not vital bone, just calcium, block of calcium, and after removing the screws, the bone block fell off. Here's another picture of bone block transplantation. Here's a not smoker, tea drinker, yes, lots of tea. And here was a bone block transplantation, and you can see here no soft tissue wants to grow on this bone block because the bone block is dead. So the question is, especially in Germany, a big question: what is the gold standard for tissue or bone augmentation? Is autologous bone the gold standard, or do we have something else? Do we really have can we transplantate living tissue, and does this tissue survive? And if we take a look into the literature, we see lots of cases or lots of studies which show that this bone is not living after a transplantation anymore. No evidence for cellular survival after transplantating living bone. So we have to ask ourselves, do we really need autologous bone, or can we take allograft bone rings? And this now we get to the bone graft classification. Just a short statement. We have organic bone grafts or bone substitute. Of course, number one we talked about is autologous bone, the patient's own bone. Then we have allogenic bone. It's a bone from human donors. We mostly use allogenic bone rings this time, and xenogenic is bone substitute from other organisms like bovine or porcine bone graft. And on the other hand, we have synthetic bone graft. It's called alloplastic. It's totally synthetically produced. We don't need, or we don't use it here in this dental office. If you want to do bone ring augmentations, of course you can harvest almost everywhere where bone is. You can harvest a bone ring, or you can allograft. You can use allograft bone rings. So if you use autogenous bone rings, they are all different depending on where you have harvested them. And let's have a closer look to the first kind of bone ring. You can harvest it at the retromolar region. The handling sometimes to harvest this bone is not that easy, because you have to work at the area of the wisdom tooth, and the quantity of rings is limited by about 2, maximum 3 rings from the retromolar area. But if you harvest it in the right way, the risk of paresthesia is very low. We have a big cortical part on this bone and less cancellous bone. That's a bit tricky for the bone ring augmentation. A little bit easier to harvest, and the handling is the bone from chin area. Everybody who wants to start with autologous bone rings should start at the chin area. The handling is much easier, and you can get out up to 4 rings between the foramina of the nervus mentalis. We have a bigger part of cancellous bone and a little bit less of cortical bone, and that's easier for the bone ring augmentation. Please keep in mind, don't harvest bones in the midline of the lower jaw of the mandible, because here very often the bone is very hard and strong, and it's very hard to get a good bone out of the symphysis of the mandible. Always get a little bit to the side. The best quality of bone rings you get at the Processus Palatinus. The handling is a little bit more difficult. Quantity of rings is limited by the missing teeth, because you should only harvest a bone ring at the area of a missing teeth. Otherwise, could be that you hurt the root of the tooth. Cancellous part is bigger, and the cortical part is a little less, and that's a very good quality of bone rings for bone ring augmentation. As maxillofacial surgeon, of course, we tried out bone rings from the iliac crest. It's my time at the military hospital. The handling is, of course, very easy, and you can get up, if you want to, 10 rings at each side. Of course, we didn't do that, but the quantity of rings is almost unlimited. You have a big part of cancellous bone, a little bit cortical bone, but the difficulty is it's a control ossification at the embryogenesis. That means we have a great resorption. Up to 30% will resorb during healing time, and that's a lot. You can see here we used a diameter of 8 or 9 millimeters because we know that it will get resolved over augmentation. Yes, it's the only picture of our bone ring from the tibia. The handling is easy as well. You have a big part of cancellous bone, less cortical bone, but the quality is very bad. As you can see here, it's a very soft bone, and I wouldn't recommend this kind of bone ring for augmentation. And of course, last but not least, our allograft bone rings. I would say 90–95% of our augmentations we use allograft bone rings. Yes, the handling is very easy. You just have to open the package. Quantity of rings is unlimited, and they are made totally of cancellous bone. And I would say it's much easier to use them for the bone ring technique than autologous bone rings. Our concept is that we use allograft bone rings surrounding the implant, and we use bovine substitute like cerabone to fill up the gaps here for the outer layer. Why do we use allograft bone rings? Because they are resorbed fast and they have a fast remodeling in the patient's own bone. We use cerabone bone substitute as a layer outside of the ring for long-term stability. And I said in the beginning, it's a kind of guided bone regeneration. That means we have to use a membrane. It's the principle of bone ring technique. We use allograft around the implant. We cover it with xenograft, bovine material, and then we use a membrane to avoid the soft tissue cells to grow in. Now it's up to you to explain about.
Yeah, we're running a lot of courses. And thank you, Thomas. We're running a lot of courses, and my favorite are always our anatomical courses. We did it in different countries, starting up in Austria and in Vienna from the Anatomical Institute in Vienna, and we're working on fresh human cadavers, and we have only the heads, of course, and each couple share one head, and we assist each other. And this is the best training what you can get if you do this kind of augmentation procedure surgeries. On a fresh human cadaver. And this is an anatomical training center, of course, last year and this year, November, and I hope it can happen because this is my favorite kind of courses. And we do a lot of this course also in the United States, in different cities, and I love it to go there and to make training on this anatomical preparates with our friends and partners from the United States. And we are well equipped in Vienna. We have space for 40 participants. And again, each couple have one head and assist each other. And we show on a so-called master skull also exercises, and it's monitored to the screen, and then the participants did it by themselves. Again, for me, the best training what you can get. And these are international courses, people coming from all over the world, and these courses are always in English. And you see, this is our partner from Austria, and we have some Austrian trousers because we like to be traditional. Ja, oh, sorry. Jetzt muss ich nochmal zurück. Yeah, this is the question is always, what is the best indication to start with a bone ring? And this is in my opinion, this is one of the indications. This is the premolar area, maxilla. Handling is very easy. This is usually not the high aesthetic zone. Sometimes it is, but usually, and there are not so many dangerous areas from the anatomical point of view. If you find a case like that, I recommend to start with a ring technique in an indication like that. And you see, after raising the flap, we have a very thin crest, but we have no buccal bone at all. And we harvest one bone ring from the chin, and you see this nice ring with a cortical and a lot of cancellous part. And now you have to understand the cancellous part of the ring is bone marrow, and in this bone marrow we have stem cells, growth factors, we have everything what we need for reossification, for revascularization. And this bone marrow you bring in a very close contact to refreshed bleeding local bone, and it has to be revascularized because it fits. Now, this is an advantage from the bone ring technique because the graft fits very perfect into the ring bed. Again, you see, before we start, we fix the implant position with a pilot, and then we have a trephine with a pin. The pin comes into the pilot socket and guides the trephine to the right position for the ring bed preparation. And now you see we have bleeding local bone, and the ring comes inside, and there's no gap, and we have a close contact from this bone marrow to the bleeding local bone. Bone graft material around, membrane, and a wound closure, and a half year later, you just have to make a re-entry and impression for the prosthetic restoration. So. And this is the only contraindication what we have when you want to make a compensation of a defect or augmentation. If you have a very thin crest and the crest is parallel thin down to the bottom, then you can't make a splitting. Then you have to go for a two-step surgery first to make a lateral augmentation with a bone block and make your implantation 2 or 3 or 4 months later. And this is now we want to show you some indications. I want to show you now some older cases to see how they're looking after many years. In this case, I have to extract all the 4 incisors in the mandibula, and we make a augmentation to get a reconstructed area with 2 implants and a bridge later from on 2 implants to compensate this profrontal maxilla mandibula. After raising the flap, you see we have a huge defect. At the deepest point, we have to make 4, 5, 6 millimeter vertical augmentation to get enough bone height later for a nice aesthetic. In this case, it's easy. I just go a little bit deeper from the defect into the thin area and harvest the ring and make just a transposition from the ring 1 level up. First ring, implant bed preparation into the ring. Second one, and we don't harvest the rings from the symphysis, only left and right. This is very important because in in the symphysis you have only cortical bone, and this is not very good quality of the bone technique. But here you see we have a nice cancellous and a cortical. And I just harvest some more cancellous chips out of the defect. And now close your eyes. And this is what we do. And we suck out blood out of this donor side and store the ring inside of the blood of the patient. And usually we fill up this defect only with collagenous sponges. In this case, I take the tree fine again, and now I harvest a bone block additionally from the symphysis, not a bone ring, just a block. In between, here, one bone ring, the second comes here, and in between, I just harvest a block, a cortical block. And also this defect I fill up with a collagenous sponge. And now we start up a ring bed preparation, starting with a pilot. The orientation is very simple because we have the orientation from the extraction socket for the right implant position. And then we remove this bone chips and fix the first implant through the ring into the local bone. Always a little bit subcrested. This is highly recommended that you use a implant system where you can do that, because we like to have bone later stable on the shoulder of the implant. The first ring and implant is in position. Removing the carrier and fixing the ring additionally, finally, with the so-called fixation cap. Also, the first one is in position. Now we go to the next one, ring bed preparation with a tree fine with a pin. You remember, removing the tips and fix the second ring with an implant. Removing sharp edges, this is always a must. Never leave some sharp edges on the ground. Now both rings are fixed and with the implants, and now we have this gap in between the two rings. And for this, I use this small block coming in between from the symphysis. It's this construction. I harvest one floor down and lift it up to this area. And now to make it even, I fill up the gap in between with a block coming from the symphysis. And the block is additionally fixed with a bone screw. Also remove sharp edges. This is always very important, fixing the membrane and put some tips into the gaps. And as a final layer of slow resorbable bone graft material around our graft. Fix it with a membrane. And then I have to remove the epithelium, because you remember we make extraction and immediate implantation. For a safe wound healing, we have to make a de-epithelialization of the borderlines of the flap. Let's say a serious transition and okay. This is the prosthetic restoration, and here you see day of surgery. The rings coming from here. One is here, and the second one is here, and the block is in the middle fixed with a screw. This is already 2 years after loading. This is 3 years after loading. You see, very stable, and the patient is on the way to lose all the other teeth on the left and right side. And you see this is loading. This is 6 years after loading. This patient has so she doesn't take care anymore about her teeth, but now she is healed, and 12 years later she has an overdenture with locators. But you see in the middle where we did this graft with 2 rings from the chin and the block in the middle, we have a stable bone already after 12 years. this is a similar situation, extraction of all 4 central and lateral incisors, 1 ring, 2 ring block in the middle, half year later, stable healing. And now this is what I like to show, because my favorite is the processus palatinus, because Thomas told you the best bone quality comes from the palatinus, and that's why I like, if I have defects in this frontal area, to use this area for harvesting the rings, because I stay at the same place. I don't have to open up another area. And you see, this is from the lateral side. I remove all the cannulation tissue. And you see, we need 4 or 5 millimeter vertical height, and we have no buccal bone. These are real 3-dimensional defects, and this is ideal for the bone ring technique. Again, I make my precision right after raising the flap to release the flap, because then later, when I close the wound, make wound closure, then the bleeding stops, and so I avoid hematome and swelling. Now I continue with my vertical incision to the palate and expose the bone on the palate from where I want to harvest the bone rings. I cut the nervus incisivus. This you can do. This has no consequences for the patient. I expose the bone on the processus palatinus. And then I measure the defect, and then I start up to harvest the bone rings from the os palatino, from the processus palatinus. You see the pilot, and you see how deep I go in. These are 8 millimeter to come in contact to the buccal side, to the cortical bone from the buccal side. Final 3 fine cutting, first ring, and then I go to the recipient side and the next one. So next ring in position. And so now I fix the second ring with this implant. And you see how nice we reconstruct the UG alveoli, and also we compensate this defects on the level from the bone covering the roots from the adjacent teeth. This is what you can do with rings in the frontal maxilla in the aesthetic zone. So now the final fixation with the fixation caps and membrane, bone chips, bone graft material around, and the fixation of the membrane. And you see here on this video from the lateral side where we end up after augmentation and where we're starting. What we get 4, 5, 6 millimeter vertical height to compensate this defect. And now this is the so-called double layer. I do this is a very safe technique. I make again an incision on the inner side of the buccal flap and make a mobilization of the perius out of the flap. I prolongate the flap with a perius. You see it here. And then with 2 vertical mattress sutures, I first suture the perius under the palatinal mucosa. You see it here. Now I pull the perius under the palatinal mucosa, do it on the other side as well. And then I close mucosa on top. And the advantage from the bone rings harvested from the palate is you stay at the same area. You just have to open as another one. This is a little bit more or less traumatic for the patient. Good. This is healing double meander technique for 2 implants. And you see, this is after suturing, prosthetic restoration. And this is post-op X-ray, 6 months and 3 years later. You see, after this 3 years, we have a stable bone on the shoulder of our implants. If you do this double layer for a safe wound closure, take care of the nervus infraorbitalis. The nervus foramen infraorbitale you can palpate very easily, and this nerve has 3 branches. These are pictures we did during our anatomical courses in Vienna, and you see one of this branch running very close under the floor of the nose. You see it here. These branches from the nervus infraorbitalis. And if you look at this patient picture, it's clear. If you do this double layer, not to make your incision too close under the floor of the nose, not to cut one of these branches. And if you do cut one, patient has a numbness in this area. This you have to avoid. Another case I like to show from the bone rings harvested from the os palatinum. We have defects from the lateral incisors, mobility 3 from the central incisors. Treatment plan is extraction, socket preservation from the central incisor, compensating of the defects from the lateral incisors with 2 rings from the harvested from the palate. And Thomas told you, never harvest bone rings on top of roots. This is dangerous, only in edentulous areas. And then you have sometimes 8-9 millimeter rings coming from the os palatinum with best bone quality. Extraction, raising the flap to the palate to expose the bone. You see the 2 rings coming from the processus palatinus. Nervus incisivus you can cut. We store the ring inside of the blood of the patient. And this is what we fill up with collagenous sponges. Now we make a ring bed preparation for the first ring in position, second one. And on this picture, you see again how nice we can reconstruct with this ring design graft the design of the maxilla like Yuge alveolariae. There's no other graft design where you can do it nice like that. Then we fix a membrane, bone graft material around, and we have to make another vertical incision because we want to cover each ring separately, because here we want to make socket preservation. And we do socket preservation with gingiva grafts from the palate, from the soft tissue from the palate. And you see now surgery is done. One ring from here is placed here, one from here is here, and socket preservation with 2 gingiva grafts. X-ray 3 months later, and the healing of the soft tissue 6 months later. Then we go for re-entry with a meander technique. And then we fix a screw retained temporary, because here we want to create ovate pointix. This is to get a nice gingiva or emergence profile. This we did do with the lab-made temporary. And you see after a while we have nice ovate pointix, and we are ready now for the prosthetic restoration. And this is now the prosthetic coming from here. And this is 4 years after loading. You see, again, we have nice bone on the shoulder of our implants. And now this is a nice indication for the rings os palatinum, especially in the aesthetic zone from the frontal maxilla. And now I hand over to the Tommaso.
Yes, thank you. Bone ring technique in sinus lift. It's, in my opinion, one of the best indications for the bone ring techniques. Especially if you have just 1 or 2 millimeters of sinus floor, and if you can't achieve primary stability to the implant during a sinus lift. And the principle is that we bring the ring inside the sinus and we fix it with the implant. And as you can see on the picture here in the sinus, we put the cancellous part to the bottom and the cortical part to the top. That's because the bottom of the sinus is not even, it's always a little bit concave, and it's better to put cancellous part here. Mostly, every time you need a fixation screw with a larger diameter than the implant to generate stability. This is one of Bernd's cases, long time ago. Many years ago. I was at school, perhaps, when you did this case.
The second World War.
You can see here is a paper-thin sinus floor like an eggshell, and at the second premolar we have a huge defect. And now we see the procedure. Of course, you have to do the window, lateral window, and to elevate the Schneiderian membrane. Then he got to the chin area. He harvested 2 rings. And this here you can see this ring has a larger implant bed preparation at the cortical part, and this ring, the hole is a little smaller. This ring here is for the sinus, and this is for the ridge augmentation. It's special. How would you describe it? It's important for the fixation,
for the stability.
And here you can see the ring is inside the sinus. There's some bone substitute material on the left, on the right, and on the palate. And this here is the ridge augmentation outside the sinus. Fill up with bone substitute material and a membrane, of course, on top. And you can see harvesting the rings was here. And one ring now is here, and one ring is in the sinus. This is about 4 years after loading. We have stable conditions. Now comes another case.
Yeah. Now I want to we come to an indication for me the most difficult part, the vertical augmentation in the hypertrophic distal mandibular. I think you agree that this is the biggest challenge what we have. If you have a case like this and patient wants to have implants here and to lift up this bone vertically, this is the biggest challenge. And I want to show you, this is more than 10 years ago. It was my first case where I thought I have to make now the bone ring technique works nicely, but I want to start up to try to do also vertical augmentation. And this was my first patient. I did it. And she's still my patient. I want to show you later. She was in my clinic, and you see we have only here 5 millimeter down to the mandibular channel. And if you want to insert an implant here, you have to leave a distance maybe 2 millimeter, and there are only 3 millimeter maybe left for primary stability. This is why we need an implant system where you can achieve primary stability with 2, 3, or 4 threads into the local bone, because here we want to lift up 5, 6 millimeter vertically. And this is how it should look like. We fix the rings. We make a ring bed preparation here and fix the rings on top with a fixation cap. And you see it's done already. The rings coming from here, one is here and one here. And this is 2 years later, from here to here. You see very stable bone. This is 6 years later. And I had a picture, but we don't put it into the, it is 12 years now ago, but it looks exactly the same like that, but we don't have it here. But if you see after 6 years, if you have a stable situation after 6 years like that.
So let's get to the topic again.
And because I know that the vertical augmentation works with this bone ring technique, we treat also cases like that where you have only 2 or 3 millimeter down to the mandibular channel. I take a ring from here, make augmentation, put bone graft material around, and you see from here to here, 5 years later, we have stable bone. even if this is only a little bit bone, maybe 2-3 millimeter on top of the mandibular channel, you can get bone height after bone ring augmentation. This is standard procedure in our clinic, things like that we want to make vertical augmentation with 3 rings in a case like that. And I want to show you this video shortly. It's always done in general anesthesia. We can go a little bit faster. I go to the pin for harvesting the 3 rings. And very often you get very, very nice rings with a very good bone quality. And if you do it in the right way, you can make it without any problems. With a drill knife, you move the ring, and you have a lot of cancellous bone. And the next one, you see again, very nice ring quality coming from the collagenous sponges. Then goes in one layer. Ring bed preparation, removing the surface, the collagen bone from the surface, bleeding bone. We have collected course with chips later for additional augmentation. And if you do in treatments like that, I recommend to put the rings in contact with it, like that. These rings are in contact with each other, 5-6 millimeter vertical. And removing sharp edges, this is always very, very important. And you see final fixation with a fixation cap. Then we put a membrane around, bone graft material, and the wound closure. And you see here, this is post-op X-ray. The 3 rings are in contact to each other. These are 5-6 millimeter vertical height. And again, you see this cancellous part of the rings, how it's changing after 6 months to trabecular structured bone. And this is during the surgery. And this is 6 months later. And this is the re-entry. You see the rings are, the rings are growing together. This is bleeding bone. After 6 months, stable bone on the shoulder of the implants. And this is 4 years after loading. From here we are coming. You see how nice and stable the bone is, not only trabecular structured bone. And this is now the situation after prosthetic restoration, with we have keratinized gingiva. And you can do the same with rings coming from the retromolar area. This is also a good place, because you don't have to open up another one, you can stay here. And in this case, I harvest 1, 2, 3 rings from here and make vertical augmentation in this area. And you see, this is 1 year after loading, and this is 6 years after loading. Again, stable bone, and the rings coming from here.
Thank you. Now I'm going to talk a little bit about allografts. There's a big discussion in Germany if we use allografts or autologous bone rings or bone graft material. And when we are talking about allograft, we have to have a look how this allograft is proceeded, because there are a lot of different kinds of processions for the allograft. Germany allowed is demineralized freeze-dried bone allograft, freeze-dried bone allograft, and cypro-preserved bone allograft. All these kinds of bone allograft in below, in red, are not allowed to use in Germany. And mostly we get 2 questions by our participants of the courses about allografts. Question number 1 is, what about the transfer of any diseases? And question number 2 is, what about immune reactions? And when we use such a modern art of allograft bone, then we don't have any problems with immune reactions or with diseases. So these are the most common questions about allografts. No transfer of diseases like HIV, hepatitis in the last 20, 30 years if you use these kinds of allograft. If you want to use a bone ring technique, you should know about the configuration and the possibilities of the bone ring technique. And here I show you the 4 most common kinds of bone defects. For example, a bone defect surrounded everywhere by vital local bone, for example, in extraction sockets, is a very, very good indication for the bone ring technique, because we have a good contact between the bone ring and the lateral bone. If you use a 3.5 millimeter implant for a 7 millimeter bone ring, the distance of this allograft is 1.75 millimeters. So new bone has to grow in 1.75 millimeters. Another indication is in the frontal maxilla. Perhaps front tooth is missing, and you have a loss very fast of the buccal wall. And this is a very good indication as well for the bone ring technique, as well as two walls, the buccal wall and the palatinal wall, are missing. You can achieve very stable conditions with the bone ring technique, and you get a good contact between the local bone and between the bone graft. The most challenging augmentation procedure, as you told us a few minutes ago, is the hypertrophic distal mandible. And if you want to gain only vertical augmentation, as I said, like if you put the ring on the bottom and you want to only gain vertical dimension, then you should stop at about 5 millimeters, 5-6 millimeters, and you shouldn't use a bone ring of 8 or 9 millimeters, because then it wouldn't be that predictable that you get good bone quality after that. That's a take-home message. Only 5 millimeters of fade if you want to do vertical augmentation, only vertical augmentation, not surrounded by any other bone. This is a bad example of over augmentation. A hip graft was used, and the surgeon didn't take care of the bone covering the adjacent teeth, and that was a very bad example of over augmentation. Of course, you have gaps here, bacteria will get in, and you have to remove this here a few weeks later. You shouldn't do that. Almost same conditions, but here the surgeon respected the bone to the adjacent teeth. Yes, it was Bernd. I respect it. Yes, use bone rings, and yes, respect the bone covering the adjacent teeth. Don't do an over augmentation. Stable conditions 6 years later. That's the case for the sinus lift with bone rings. It was made by Chris Śmielewski from Poland. And this is a kind of surgery which makes a lot of fun. I like it very much. You can see here, it's like an eggshell, the bottom of the sinus on the right side. On the left side, a little bit more of bone, but not enough to get primary stability. And we want to set the implant 1 or 2 millimeters subcrestal most of time. And then it gets not that easy to place an implant there. And what he did is, after the lateral window and elevation of the Schneiderian membrane. Then he did the pilot drilling for the implant bed at some PRGF membrane, bone substitute on the left, on the right, onto the palate, max Graft bone ring, and here he screwed the implant outside of the mouth into the implant, into the ring, and then has put the ring and the implant inside the sinus, and then he fixed it with the so-called membrane screw. And with this technique, you get the implant placed 2 millimeters inside the bone. Then after that, add further bone substitute material, membrane, PRGF on top, and soft tissue closure. And it was done on the other side as well. Elevation of the Schneiderian membrane. Here's a septum. And bone ring inside, and the fixation screw outside of the bone.
And for me, Thomas mentioned it already, this is one of the most interesting and nice indications if you use allograft rings, if you have a sinus situation like that. There's only 1 millimeter, maybe less. And there's a septum, you see it here. And the treatment plan was to insert 3 implants, 2 here and 1 here. And after extraction, and you see, I make a window mesial from the septum and 1 distal, and you see that I expose the septum. And in the distal area, I insert 1 implant through the sinus floor into the ring at the sinus, and fix it from outside with a fixation cap. And it's like a sandwich. I connect with the implant, the sinus floor, with an implant and ring inside, and outside with this fixation cap. And so I get a very, very good stability. Bone graft material around. And this is the X-ray post-op. You see there was a septum, 1 implant mesial, 1 implant distally with a ring inside of the sinus. And this is 1 year after loading. You see we have a very stable situation. And I think this is a very nice indication to go for 1-step surgery, even in a compromised bone on the sinus floor, maybe 1 or less than 1 millimeter. And this is a fixation cap. You see the fixation cap comes into the cover screw, and with a wider diameter, the fixation cap is located on next to the implant on the sinus, on the crestal bone, and gives this stability. Okay, I told you usually, or Thomas told you, usually vertical augmentation should be limited 5 millimeter. But sometimes, if we are lucky, we get also cases like that. You see, this is a huge defect, and we have sometimes 8 millimeter. But this is not predictable. I don't want to recommend you to start up with cases like that and to be brave and try to get 8 millimeter vertical height. Another case, very nice indication for an allograft bone ring. This is there was a cyst, a big cyst in the mandibular, and you see no buccal and no lingual bone. I put the ring inside and compensate this defect and fix the ring with an implant. Bone graft material around. And again, post-op, you see the translucency of the ring and how it's changing after a while, latest after 6 months, and changing to get a trabeculaire structured bone. It's always the same. And this is the ring, how it looks like 6 months later. You see, this is vital bleeding bone 6 months later after bone ring healing. And this is a gingiva design, ceramic abutment, prosthetic. From here we are coming, post-op, 6 months post-op, and a couple of years after loading. You see, we have a very stable bone situation used. And this is a message if you do it in the right way, you can use also this allograft rings, makes it much easier, and you have the same success after prosthetic restoration if you do it in the right way. This was a nice case I did here in the clinic. There was a patient who comes to our clinic. This is 2 malpositioned canines, and he said, "Doctor, I need implants, but I have no money." And I say, no money is a contraindication for implants, but you have such a case, I will treat you for free. And we make a osteotomy of the canines, fill up the defects with a ring, and you see huge defects, bone graft material around. On the other side, the canine was located like that. There was parallel to the crest a huge defect, and here we put 2 rings on top of each other to compensate this defect. And you see again, post-op translucency of the ring and how it changed after half a year to topically structured bone. From here, and you see this is bone graft material on top of a ring, and you see 6 or 8 months later, we have only stable bone. This is the situation coming from here after 8 months. And this is the situation after healing. From here we are coming, 10 months later, 1-step surgery. And what we did, because we want to know what happens inside of this allograft rings after 6 months. And we take a lot of histological probes from the allograft ring after 6 months of healing. And we find always the same situation. You see the empty lacunes from the is allograft, and the vital bone cells growing from all sides into the allograft. And we find out that latest after 2 years, you don't find any kind of allograft. The allograft is completely changing into vital bone. This is a situation from this patient with a prosthetic restoration. And this I can give to you. If you like. And this is I did in another country, I think in Lithuania. I did this case. This was a colleague from us. You see, colleagues have the most worst teeth, and we have to make extraction in 1 step. And he left us very nice defects. And this case is very interesting for us because we did a combination. I take 1 autogenous bone ring from here and put it here, and the other defects I compensate with allograft rings. You see, I take 1 autogenous bone ring to this place, and here's allograft, allograft, allograft. And you see, after a while, the autogenous bone ring is in the mesial defect, and the distally defect, I take an allograft ring. This is now very interesting, the behavior of these 2 rings, 1 patient to 1 side, same indication. On the other side, I use only allograft rings for this vertical augmentation. And bone graft material around. And this is again post-op. The autogenous ring is here, allograft, allograft, allograft. And my colleague in Lithuania, he makes a re-entry, and he has to remove from each implant bone to get access to the cover screw from the on top of the implant. And he also takes a histological probe, removing this bone. He takes a histological probe, prosthetic restoration. From here we are coming, and here we are. And at the end, you see no difference between autogenous and allograft rings. There's really no difference. And this is 1 year after loading. Here's the autogenous ring, allograft, allograft, allograft. Now
that's my turn. Yes. And I will show some cases of mine. When I was practicing in Hamburg, that's a very good indication for bone ring technique. This patient came to the clinic and he had a micro movement of the implant, and he had pain when the implant was under pressure. So I was able to remove the implant, turn it out, and there must have been soft tissue in the threads of the implant. And what you can do here is that you take out the local bone with the soft tissue and replace it with the bone ring in one step. You can see here during the surgery, the X-ray, here was the allograft bone ring in complete length, 10 millimeters. Of course, we have cut it into the right length and placed the implant directly. And that's a very nice indication for the bone ring technique, or if you want to replace a broken implant, for example. This patient is a little bit older case from a time at the military hospital. You can see a great loss of bone at the 3 implants here. We had to remove it, and it was a great vertical defect. And we used 3 bone rings from the chin. The middle bone ring we filled in like an inlay. Of course, you have to smoothen all the sharp edges. That's after surgery, soft tissue closure, and this is 6 months when we did the re-entry. And as we have shown a picture before, it's the same result. The bone rings have grown together, and you can see local bleeding points out of vital bone. Gingiva formers, and here you can see the problem with German soldiers. They get paid everything, augmentation, implantation, but they don't get paid for hygiene, for professional tooth cleaning. So they don't want it. We got 1 ring out here, and 1 ring here, and 1 ring here. And this is the final prosthetic. It's not very nice, but we have a Sprichwort in Germany. We say a German soldier doesn't have to look nice. He should frighten somebody else. Okay. This is one older lady. She had an orthodontic treatment, and as you can see in the panoramic X-ray, we have a lot of damage to the tooth, and we had horizontal loss of bone. And this is how I did it: bone ring at the second incisive and the second bone ring to the canine. And again, here the best thing is if you bring the 2 rings into direct contact to each other to stabilize everything. And a bone ring here at the back. Then I left the dental office in Hamburg and got to Kassel. So I'm sorry not to have any follow-up X-ray. This is a nice other indication, implantation to the second molar. And as you can see on this detail X-ray, he has loss of horizontal bone. And you can do the augmentation during implantation. It doesn't take a lot of time, perhaps 15 minutes longer than normal augmentation. You place the implant and the bone ring surrounding the implant. Then you add your bone substitute and put a membrane on top. And that's the picture after surgery. It doesn't take much longer than normal standard implantation. This is a very interesting case. If you take a look on the right side, we can see in the panoramic X-ray bone substitute material, perhaps after apicectomy. And that's the DVT, the cone beam. You can see we have a defect at the palate, a bony defect here. And here is the bone substitute material. We don't have a lot of bone, so we needed an sinus elevation and augmentation in one step. There was a little perforation of the Schneiderian membrane, but it was no problem. And here you can see the defect of the palatinal bone where I've put my rasp inside. So we follow the protocol, the step-by-step procedure. First create the ring bed, then place the ring and the implant inside. Of course, you have to cut it into the right length and combined with an external sinus lifting. Add some bone substitute material on the outside, cover it with a membrane, and here I fix the membrane with the fixation cap, and then apical mattress sutures and soft tissue healing, and the second layer of knots. Sinus lift, as I told you a few minutes ago, for me the best indication for bone ring technique if you have only a very little bone at the bottom of the sinus, like here. It's an old lady. She was about 80 years old, and she had to take care of her husband every day, every morning, every midday, and every evening. But the husband had to go to hospital to get in surgery, and she told me that she's 1 weekend off and she wants to have locators for her upper denture. It's a very bad bone situation. It's, you can see here on the cone beam, and here again only an eggshell of the bottom of the sinus. There was one location I did an expanding the bone or bone splitting, and in the back I put the bone ring inside the sinus and fix it with the implant, and on the other side as well. And this is the X-ray after surgery. One bone ring is here, bone split was here, and the other bone ring is here, and that was a very good indication. One-step surgery, implantation, sinus lifting together. Soft tissue healing. And that's a case of you.
And now I want to show you finally a case I like very much because I learned a lot from this case. And on top, this case is already 12 years old, and not 12 years, 8 years old, sorry. And this was right in the beginning when we start up to use Allograft rings. And this lady comes around like that. She had a huge defect. She lost central and lateral incisors. And the interesting part is that she had 3 bone block transplantation who failed. And then she comes to our clinic and heard about the ring technique, and she was so afraid and said, "Doctor, I only once in my life I want to do again and try, but if it doesn't work, I will never want to have a surgery again." She was so traumatized, and she said, "I prefer to use a removable temporary for the rest of my life." And she was only 36 years old at that time. And then I say, okay, we will do it with our technique. And on top, the biggest punishment for implantologists is working in the aesthetic zone from the frontal maxilla. If a patient like that have a gummy smile, and she had a very, very, very much gummy smile. And so every single millimeter counts to get it symmetric to the other side. I measure the defects, 7 millimeter for the central, 6 millimeter for the lateral incisor. I take 1 ring from the chin, make a compensation of the mesial defect central incisor with a ring and an implant with autogenous bone. And the other one, I take an allograft ring. This is now very interesting. Autogenous bone ring, allograft ring next to each other. And you see, we reconstruct the maxilla, 6 mm vertical with one autogenous ring, with allograft ring, 1 mm bigger for a central, 1 mm smaller for the lateral incisor. And again, we know that the biggest problem, if you have one implant next to each other, to get a nice papilla between two implants. And because I know that, I thought I will be very clever and make a so-called scallop design. I leave the bone between the implants a little bit higher to support my soft tissue like a papilla. You see it here. I leave it just a little bit higher. Autogenous ring, allograft. Then bone graft material around, membrane on top, and on top of the membrane I put a PRF membrane. I do everything, nothing else could be done more in a case like that, because now it has to work. Apical mattress sutures, cutting frenulars, takes the tension away from the mucosa to have a very, very safe healing. X-ray post-op. We leave the apical mattress sutures a little bit longer in time. And this was 6 months later, the soft tissue healing. Papillas here looks not bad here, but in between, okay. So and you see, after 6 months, she just moving a little bit the lip and you see everything. This was an X-ray 6 months later. From here we are coming. And this is now the prosthetic restoration. 8 years after prosthetic restoration. From here we are coming. And this is 8 years later. Papillas here perfect, but here so-so. You see, it's very difficult to get a nice papilla between two implants, and but she was very happy because she never expects that she can get back a nice smile like that after this history of 3 failed bone blocks in the frontal maxilla. So this was a short excursion into the bone ring technique, and I will hand over again to Thomas, because we have also some papers done about the bone ring technique.
Yeah, it's a short thing. We did an examination of about 120 patients who got allograft bone rings, and it was accepted by the Journal of Oral Implantology with the title One-Stage Vertical Ridge Augmentation Dental Implantation with Allograft Bone Rings Results 1 year after surgery. If you are interested in this examination, you can send me a direct message and I will send it to you. There are several, how you call it, papers. You get more and more papers about the bone ring technique if you search for it at PubMed. So that's it for today.
Yes. Thank you for listening. I hope it helps you a little bit to rise up your horizon. And in case you want to discuss with us, we have this channel, and Thomas takes care of it. And we promise you, if you want to communicate with us, we will answer, and if you get in contact with us, and we are open for everything. And if you have questions about the case, just contact us and we can discuss.
It's a call, yes. Yeah. Yes. And if you want to, we have some minutes left. You can write us any questions you want to in the chat. And we are here for the next minutes to answer.
1 minute.
1 minute. Or we can start with the most common questions after our.
Let me just summarize something. So bone ring technique is a very safe technique, but everything depends on a very good soft tissue healing. The key of the success is that the wound keeps closed. And the biggest problem when I discuss, I do it so many years, is always what to do if you have a dehiscence of your wound. And that's why we have a special course only for that. We show how you can achieve a tension-free flap on top of a graft or a bone ring graft. And there are different techniques in different areas. And I think this is the key for the success. If your flap keeps closed during healing, it will work 100%. And this is my take-home message.
Another thing is, didn't mention that you have to to follow the step-by-step procedure of the bone ring technique. We didn't get too much into detail, but it's you have to follow the step-by-step procedure completely. And if you do anything
in your way,
it could be that it gets a total failure.
The technique looks easy, but it is not that easy because it's very technique sensitive. And that's why we offer these courses that you can get a step-by-step education. And if you got it once and you finish your learning curve, then you got it and you can solve many problems with a bone ring technique in your daily surgery life implantology.
Herr Dr. Nord, wir haben ein paar Fragen erhalten.
A little bit easier than autograft bone rings because you don't have to harvest the ring, and it's important how you prepare the bone ring when it's still located in the local bone. There are some differences in between the handling of allograft and autogenous bone rings.
And,
Herr Dr. Nord?
Again, if you have some questions now at this moment, we are here. But if you have some later, you can write us or give us a message.
Herr Dr. Nord?
We have here some questions, perhaps.
Yeah.
Greetings from Egypt. Hi from Italy. How about augmentation procedure for posterior side? Can we use this technique after we do sinus lift procedure? Yes, you can do.
Mm-hmm.
Which instrument sets is used for the bone ring technique? It depends on if you want to use allograft or autogenous bone rings. Allograft bone rings in Germany or Europe are sold by Straumann, Botis Straumann. And there you can get the ring set for allograft bone rings. If you want to use autograft bone rings, you need a larger set with more instruments. It's sold by the company Meisinger. Not Meisinger, Set. I'm sorry, by the company Set.
These are the details, and it's not easy in a 1.5 hour to talk about these details. That's why I recommend, if you are interested, come to us or join a course or something like that, and to see all the different instruments, how they work together, and how we have to use them.
While inserting the implant, how do you stabilize the ring? Do you do pull with implant osteotomy with glass drill inside the drill before implant placement? So how do you stabilize the ring? You can use a forceps or a normal forceps to stabilize it. If it turns around during implantation, it's the wrong way, I would say. You didn't.
But if you use allograft rings, for example, so allograft rings are available in 6 and 7 millimeter diameter, and the 6 millimeter allograft ring has an inner diameter for the 3.3 millimeter diameter Straumann implant, and the 7 millimeter diameter ring has inner diameter for the 3.3 or for the 4.5 implant diameter Straumann. If you want to use another implant system, then you have to make a preparation of the inside of the ring with your implant set, and for this we have special forceps. And usually, if you work very precise, the ring has a press fit inside of the ring bed and doesn't turn around during inserting the implant. But if it do like that, you can stabilize it with a forceps or with a rasp. This is very easy done.
Hello to Marta Ho. I don't know if you still are listening, but we know each other. Hi Thomas, when do you use the patient's own bone, and when do you use allografts? We mostly use allografts because you don't have to harvest the bone, and it's less pain for the patient. But in the end, it's the patient who has to decide.
I always ask my patient, we have two possibilities. We can do the augmentation, opening a box and use an allograft ring. And otherwise, we can use your own bone. Then I have to go to another area for harvesting the ring. And I leave the decision for the patient. And more than 90%, 95% of our patients say, just open a box. But there are patients, they want to have their own bone. And that's why I recommend don't learn only the ring technique with allograft, just be also able to do it with autogenous bone rings, because you will have patients who wants to have only their own bone.
Next questions. Which implant type do you use? For the bone ring technique, there are 3 implants on the market with the fixation screw. It's the Ankonos system, it's Straumann, and a very new system, Implant, from the company Meisinger. We have to use it in about 45–50% of augmentations. We use the fixation screw on top of the ring.
That's why we recommend to use an implant system like that, because if your ring has a little bit mobility left and you can't fix it with the screw, then it doesn't work.
It's an interesting question. How much primary stability would be sufficient for this technique? So we do it, what would you say? Do it by hand.
Definitely with my hand. But you need primary stability anyway. This is the requirement for revascularization or bone healing, that you have a stable situation without any movement. But I don't measure it, I just feel it with my fingers.
Excellent presentation, thank you very much. Do you have any videos that show the step-by-step procedure? Yes, we have, and we will show in the future.
It will be available from Straumann as well.
Yes. And if you take a look in my account, Augmentation Implants, in the IGTV, you will see a video about it. What about smoker? We treat smokers if they don't smoke too much.
This is a special question.
Yes. Otherwise, we wouldn't have 50% of our patients.
We don't make a difference between smoker and non-smoker, but because the patients are not saying the truth always, as this is, you know it from your daily life, and it doesn't work, or it means nothing if they promise you not to smoke for 1 week. It makes no sense. I think it's your decision. Don't make a difference between smokers and non-smokers.
What kind of suture material do you use? We don't use silk, of course. What do we have in this moment? It's not a monofile, it's a polyfile filament. But yeah, you can use monofile or something else, but please don't use silk for the suturing. Polyene.
Yeah. And for soft tissue surgery, we use usually 5 or 6-0, and for the usual wound closure, 4-0.
Do you have hands-on courses in English? Yes, we have. In Vienna, you told us?
And we will have some here as well.
Later this year, I will put it on Instagram. About November, we will give a hands-on course here in Kassel, the center of Germany, in English. Thank you. Okay. When used tuber bone with soft tissue, then how do you fix it?
Yeah. The tuber bone, you mean the socket preservation. This is something what we do very often, because it is very easy and fast done. If you want to make socket preservation, to go with a tree into the tubera and harvest the bone gingiva graft from the tubera. And the tubera bone is a very soft bone, and you can compress it very easily into the socket. And the gingiva around, I suture with normal suture material.
That's almost the same question. Do you use other implant systems than Straumann? Yes, we do. Ankylos and MyPlant. You can use other implant systems as well, but then you don't have a membrane screw. If you don't need the screw, it's okay. But if the ring has still some mobility left, it would be better if you have an implant system with the membrane screw.
For the final fixation.
Yes. Do you have any inflammation after the surgery? Do you have any inflammation and syndrome after the surgery, after operation?
Our biggest inflammation comes only after dehiscence of the flap. The biggest complication what we have in a few cases is the dehiscence of the flap, and then it depends what to do. Sometimes a reclosure is very difficult. Sometimes you can make a reclosure, and sometimes, very seldom, you lose ring and implant.
What can be the minimum thickness of the ring? So the allografts here are produced in 6 and 7 millimeter. And did you ever use a 5 millimeter autogenous ring?
Yes, for the lower or upper central lateral incisor in former times.
Very tricky.
Very tricky.
Where can we buy in Spain the kit of tree finds for the bone ring? Please ask Straumann or Zap. So that was the last question. Do you have any questions, Ben?
I want to say thank you. It was a pleasure for us.
Yes.
And I like more to see my participants, but if we don't have the possibility, it's better to do it like this or than nothing. Thank you very much for your attention. You have some more questions?
2 questions are coming in.
Yeah.
When you don't have enough bone to stabilize the implant, do you use other bone augmentation techniques? If yes, which one? Do you use Curie technique? I use Curie technique sometimes, but I must say most time bone ring augmentation. But Curie technique, bone block transplantation, we do as well. Yes. Bone builder. What can be the minimum thickness of the ring about the implant? 1 millimeter? No, that's not enough, I would say. It's 1.75 millimeter. Yeah. 1 millimeter is very thin for the bone ring technique. Garcia, thank you. Hi, what about the risk of damage to nerval and at palatinal grafts? Yes, it's about nervus incisivus.
Nervus incisivus is not a problem in the palate because the patient has no numbness or and if there's a little bit during brushing teeth, it will come back. This is you can cut very easily, but of course not other nerves in other areas. And this is why we like to do this anatomical courses. We show exactly the anatomical situation of the mandible nerve, the mental nerve, nervus infraorbitalis, and so on. And then you can see very nicely how to avoid complications and to damage some anatomical structures.
Oh, that's very nice. You are amazing. Somebody wrote that. Do you use the sandwich osteotomy?
Yes. If you want to say like that, we did it sometimes, but only with rings. It is like a sandwich if you have a ring inside and outside of the sinus and you put it together to each other. But you mean this common sandwich technique? This we don't use.
I'll put a picture of the bone ring sandwich in the next days on Instagram. Do you use Oscillodensification burst to enhance the implant stability? It's the reamer, the cortical reamer. Yes, from the ankylos system. Which brand of graft are we using? We are using mostly Botis materials.
Not mostly, only.
Only.
We have a contract with this company and they produce our Allograft rings. And the tissue bank who did it in the United States is different in Europe. We have one in Austria and one in Berlin. And these are tissue banks who produces these bone rings coming from hip substitutes.
Yes, the same company for our membranes and the particulated bone substitute. Is there a problem of cracking while using Synovian material?
Yes. This is a good question. Usually, I talk about that before a question is coming like that. This happens sometimes. That during you insert your implant through the ring, and you, for example, you are not 100% exact from your implant bed to the inner diameter of the ring, then the ring could fracture. But this doesn't matter. Then you can put the two pieces together and fix it from the top with this fixation cap. This happens not very often, but it could happen. It can happen. And then you can fix it finally from the top with a fixation cap.
The advantage of the Allograft bone rings, in contrast to bovine bone rings, perhaps when you produce them, that the Allograft bone rings have collagenous shafts, and there's a little bit of elasticity.
Elasticity, yeah.
Yes, that's a big advantage. Don't try to make your own allograft bone rings out of a big allograft block. Mostly it will end to a failure. We have seen a lot of times. There are lots of YouTube videos showing the wrong bone ring technique. Do you submerge the implant in the ring, or do you keep it at bone level? We submerge it.
It's a big advantage if you have an implant system where the abutment comes a little bit smaller out of the implant, like the implant diameter. And then you can insert, then it allows you to insert the implant a little bit subcrestal, and this allows the bone to grow on top of the shoulder of the implant. This is a perfect stability. This is so-called, how we call it, I don't know. Yeah.
You should place the shoulder of the implant about 1 or 2 millimeters inside the ring, and that's a good margin for that. Do you think BLX will give a better result than BL Straumann?
Yeah, this is a good question. You need an implant system where you can achieve with a very aggressive thread a very good primary stability, and this is the key.
We didn't use BLX at this time for bone rings. Which implant is better for bone ring, parallel or tapered? Yes, we use mostly tapered. No,
Because it's not tapered. And I think this makes not a big difference.
Yeah, good questions. Is the limit of bone augmentation the proximal bone height? At the one hand, you have, of course, to respect, as I said, the bone covering the roots of the adjacent teeth. Otherwise, if you want to make only a vertical augmentation, like in the distal mandible, the limitation is about 5 millimeters.
Or if you talk about only vertical.
How can you treat peri-implantitis in the ring?
Very good. This is also a nice indication. You see, it comes more and more, but the time is not enough today to talk about that. Peri-implantitis treatment, we do
in the ring, he said. Peri-implantitis in the ring. So mostly the ring has turned over into a patient's bone after a few months. So it's you have to treat it like a normal peri-implantitis, I would say. But what you wanted to say is peri-implantitis treating.
Yeah, when we have cases where patient comes with a peri-implantitis, and then we very often use a trephine, remove the implant, and with this removing of the implant with a trephine, we do already our ring bed preparation, and then we put a ring inside and a new implant. This is done usually in one step.
Fast treatment. Okay. '54 are online, and this could be the last question.
Very good questions today.
How do you remove implants? It depends on the implant and the disease. Sometimes you have to screw it out, or sometimes we use a tree fine according to the diameter of the implant.
Okay.
Thank you, Amir. Amir told us we are amazing. We are very patient with questions and answers. Yes, we are.
Thank you for your wonderful questions and
Yes.
attention. And I hope we can see us somewhere in the future.
Yes, and thank you very much.
Have a good evening, a good night, wherever you're watching. Thank you for your attention. Bye-bye.
Bye.